My name is Joleen Hubbard, and I am a gastrointestinal oncologist at Mayo Clinic, and my area of clinical and research focus is colorectal cancer. Yeah, so currently we know for gastrointestinal cancers, those patients with microsatellite instability are candidates for immunotherapy. Unfortunately, right now, that's a small percentage of patients depending on the gastrointestinal cancer. For instance, pancreatic cancer, maybe 1%, or colorectal cancer, about 4%. So there's still the vast majority of patients that are not going to respond to immunotherapy. Fortunately, there are myriad of clinical trials that are trying to evaluate and determine if we can waken up somebody's immune system to get them to respond to immunotherapy. So for instance, we're combining it with radiation therapy to see if we can induce an immune response that then the immunotherapy can come in and help the patient's own immune system tackle that cancer. We have proposals for combining immunotherapy with a vaccine that maybe will help awaken the patient's immune system to their cancer, and then the immunotherapy can come in and give it a boost and help it work better. So right now, the patients that are candidates for immunotherapy with gastrointestinal cancers is fairly low, but I envision in the future that patient population is going to continue to grow as we develop more and more ways to awaken a patient's immune system and get them to respond to the treatment. Well, genomic profiling is key to individualizing treatment for a particular patient. So in my practice, I do next generation sequencing on all patients that I see. For colorectal cancer specifically, it gives me information on microsatellite instability, BRAF mutations, RAS mutations, HER2 overexpression, so a number of different mutations that help then guide us into which path the patient will go in terms of treatment. So it's absolutely key that we're doing this up front. Even if we don't use the information right away, for instance, for HER2 positive colorectal cancer, about 5% of all colorectal cancers, I won't act on that information right away, but I will get the patient set up for a clinical trial in future lines of therapy that are investigating these agents in colorectal cancer. So it's not only key to help us determine treatment up front, but then it's also key to help us determine what clinical trials will be available. Do they have a druggable mutation, that there's a new drug coming in the pipeline that we can target that mutation? So both from a clinical perspective and research perspective, to be able to provide more opportunities for our patients, but also individualized opportunities. So each patient is getting the best possible treatment for their particular cancer. Yeah, so I see molecular profiling as really playing a major role in the future. We've always known that people, even with the same type of cancer, their individual cancers have different biology of their disease, between individuals. And so we're starting to get smarter about what's driving that biology, and then we are starting to be able to apply treatment options. Take, for instance, patients with BRAF mutant metastatic colorectal cancer. So we knew that this was a very poor prognosis. Patients were progressing very quickly on standard treatment options, and we knew it was pretty dismal for that patient. Now we have a particular set of drugs, a regimen that can specifically address that BRAF mutation, and we are dramatically altering the course of the disease for these patients with BRAF mutant colorectal cancer. So if you take that example, we're only going to continue to find more and more examples of what particular is driving that patient's cancer. Why is it behaving the way that it is? And then tackling that specific driver of their cancer. And that's really going to help us then become more specific on the individual patient, really tackling what's making their cancer grow and spread. And if we can tackle that head on, early on, hopefully we'll be able to provide much better outcomes. There are also a myriad of other things that are being explored besides immunotherapy, besides targeted therapy. There are vaccines, there's CAR T cell therapy that's being explored in solid tumors. So I think it's just beginning in terms of the myriad of options that are being developed for cancer in general. And I think in the future, we're going to be able to examine a cancer, we're going to be able to determine what drives that cancer, and we're going to be able to give treatment to tackle that specific driver. And I'm really optimistic that we're going to dramatically improve outcomes for patients.